Welcome back to SPED 738. In this module, we're going to take a look at students with physical disabilities and other health impairments. Two diagnoses that we can use within the parameters of IDA to qualify a student with a disability. So I want to take a close look at the characteristics of both students with physical disabilities and students with other health impairments. Your text talks about a number of different scenarios related to physical disabilities and other health impairments. We're going to touch in a little bit more detail on those. And there are going to be times that you run across students with different diagnoses that maybe are a little bit more rare, that have some of these characteristics of students with physical disabilities or may qualify as other health impairment. We're not going to be able to cover each and every possibility that you may run into. But as we talk about some of these characteristics and we look at some of the instructional strategies that we can use, we look at the evaluation tools that are available for us, I think you'll have a pretty good toolkit handy when you're introduced to maybe a new student in your building that has a physical disability or other health impairment. When we look at the IDA definition of a physical disability, there's two important words I kind of want to point out to you here. The definition really uses the term orthopedic impairment rather than the term physical disability. But what it says is that an orthopedic impairment that is a severe orthopedic impairment that adversely affects a child's educational performance. So we have a couple words there that are really important for us to focus on. One is that the orthopedic impairment is severe. And the second is that it adversely affects the child's educational performance. So those are two key things that we have to look at when we look at identifying a student specifically with a physical disability. Now those can occur because of a number of things. It can be a congenital anomaly that causes that physical disability. Sometimes you may see a student that has an impairment that's caused by some sort of disease that they've had, or they may have an impairment from another cause like CP, cerebral palsy, and we're going to look at some causes for cerebral palsy because it's one of the more common orthopedic impairments that we see in schools today. When we look at cerebral palsy, 50% of our kids that we have diagnosed with cerebral palsy also have an intellectual disability. So sometimes that group of student kind of falls in that multiple disability category as well. 33% may have epilepsy, which is a seizure disorder, and then 8% have autism. One of the things that medical professionals use when they diagnose cerebral palsy is they look at the different regions that are affected by the cerebral palsy. And then they diagnose based on how many regions are affected, whether there are multiple limbs, if there's 4 limbs affected, or just 1 limb affected. And typically when we see students with cerebral palsy, they typically have some tightness or what we call spastic muscles. So there's a lot of tightness in the muscles. They may have some involuntary movements within the muscles, which is called athetoid. And then we may just see some combination of different movements within the muscles that the medical professionals typically use for diagnosis. My brother Phil, who is diagnosed with CP, he has spastic muscles, particularly in his hands, which makes it very hard to write for him. His hands are his fingers are very tight, and so that really makes writing hard for him to do. He has become a runner later in life. He's run for about 7 years, and that's really improved his gait. It's improved his posture. It really has had a tremendous impact on his muscle development. He's also lifted weights during that time, and that's also really helped his muscles. So that's kind of exciting to see how he has progressed with his CP later into adulthood. And the book talks about a number of different specific types of CP that may be helpful. But I think that the big concept to understand here is that it can affect different parts of the body, different limbs. Sometimes it can be one-sided. Sometimes it can affect both sides. Sometimes it may just impact one limb. Sometimes it can impact even the spine, the neck, the head, all of those things. And so you may come across students who have the diagnosis of CP, but they're all going to have very different characteristics in terms of how their body functions with that orthopedic impairment. When we look at the causes of CP, we have some prenatal causes, some perinatal causes which occur at birth, and then we have some postnatal causes. Some of the typical prenatal causes of CP can be an infection in utero, can cause that. Prematurity, so being born very early, can contribute to having CP. And then there may be some type of brain malformation that exists that causes the student to have that orthopedic impairment of CP. We also sometimes see students that have strokes in utero. I know a particular family whose daughter has a genetic blood disorder that contributed to a stroke in utero. And she just now started preschool, but she has definite one-sided weakness, tightness in the muscles, those kinds of things, very similar to a stroke patient. Also, in the case of my brother, there was a lack of oxygen during birth, and so we believe that contributed to his development of cerebral palsy, caused some kind of damage within the brain that contributed to that CP diagnosis. And then sometimes there can be an infection that infants encounter that can cause CP. After birth, postnatally, sometimes we can see brain injuries that cause orthopedic impairments like CP, or even things like a meningitis infection can contribute to CP. So just kind of things to be aware of as you're working with students with CP. I think it's always helpful to kind of know the root cause if the parents know that and if that information is available to you, just to kind of give you some understanding of where that student is coming from and some of the symptoms that they may have. Another very common type of physical disability that you may run into in public schools is spina bifida, or a student with spina bifida. Spina bifida is basically, those two terms mean open spine. So it's a neural tube defect. And you'll notice in the picture here we have the normal spine. You'll see how it's closed off. And then you'll see with the spinal cord with spina bifida, there's an opening within the back. Typically kids that have spina bifida, that's going to be more in the lower back, but it can occur higher up in the spine. And their characteristics, their disability is impacted by how high up in the spine that occurs. So the higher up it occurs, the more progressive those characteristics in their disability is. Some common characteristics that students with spina bifida have is some bladder and kidney issues, kind of connected to the spinal cord there, and some of the nerves that are impacted. Mobility, of course, is impacted, and a lot of times these infants, when they're born, can have hydrocephalus, so the brain is not draining cerebral fluid like it should, and they can have a buildup of pressure that has to be reduced. We've seen kind of a decline in spina bifida really for two reasons. One, the increased use of folate as a supplement during pregnancy. Increasing the levels of folate in the body reduce the likelihood of spina bifida occurring. We also have new procedures that can be done if an infant is diagnosed with spina bifida in utero. There's actually surgery that can be performed in utero to repair that open spine. And so as we see those medical advances continue, we will see a reduction in students with spina bifida in our schools. Sometimes you will see a student with spina bifida that has some mobility issues that cause them to be in a wheelchair, or to use a walker, or to use a cane, is often what we typically see with these kiddos. But it's pretty typical neurodevelopment, so really just specifically a physical impairment. Now, one of the other identification tools that we can use within the IEP process is identifying a student as other health impaired. And when we do this, we're really looking at two things. One, a chronic or an acute health problem. And those can be things as IDA is defined as asthma, ADD, ADHD, diabetes, epilepsy, any kind of seizure disorder, heart condition. If they have an illness like leukemia, rheumatic fever, sickle cell anemia, any type of chronic or acute health problem that adversely affects their educational performance. Now, when we think about other health impairments, we think about this in two ways. One is chronic and one is acute. Now, chronic are something that the student is going to be dealing with through their entire experience in school. So if they have diabetes, or if they have epilepsy, or if they have, for example, Josie has a swallowing disorder called dysphagia. That is not going away. That's a chronic condition that causes her to not be able to eat on her own and be tube fed. Okay? So she could qualify as other health impairment with that chronic condition. The other thing that we can sometimes see with students in our schools is some kind of acute other health impairment. So for example, if we have a student that has leukemia or is battling cancer, they may qualify as having an acute health impairment that provides them with services through our special education programs. Okay? The other thing that may be acute is some type of infection or some kind of injury that requires supports in the classroom and really adversely affects their learning. Okay, we had a similar situation like this, even though Josie does not qualify as having other health impairment because of her deafness. That's her primary diagnosis. But last winter over Christmas break, she came down with a really significant infection in the bone of her heel, and it was pretty serious. We were hospitalized through Christmas break. And then it took a long time to heal, and we had to be very careful with it. And so we were looking at about 3 months of using a wheelchair, slowly progressing to a walker, and we had to be very careful about any other infection that she contracted. She required a really extensive antibiotic use even during the school day. And so it really required for her some additional accommodations and modifications. And so we had to kind of meet as a team and lay out what that plan looked like for the next 3 months. That was an acute issue. It passed and we moved forward, but she really needed a plan in place during that time for some accommodations and modifications, for some physical therapy to help her work through that, and also with nursing assistance because of the medication use. So we can see students that have that chronic versus acute other health impairment. I just think that's important for you to note. Sometimes, unfortunately, in schools today where we're working, we may hear of a student that the parents have discovered they have cancer and they're battling that. That might be a time where the special ed team needs to step in and see if that student needs any kind of accommodations as their health impacts their educational progress. When we look at seizure disorders, that's probably one of the most common, besides ADD and ADHD, that we see students have using that other health impairment diagnosis. And there's a couple of key things I want to point out to you related to epilepsy and seizure disorders. One is being able to recognize those common symptoms of what it looks like when a student could be having a seizure, and then some really basic but important first aid steps when we have a student having a seizure in our classroom. During the ministry that I work in at our church, we have several students that have seizure disorders and will have seizures while they are in our program and in our care. And so we follow this process really closely. Here in a minute, I'm going to show you some documentation that we use and that I encourage schools to use when you have a student with epilepsy, just to make sure everyone's on the same page in terms of their medical care and the things that they need in place to make sure that they are safe during a seizure event. But when we talk about epilepsy, we're talking about seizures, and there can be all kinds of different symptoms that a student may have during a seizure, and they may even have some of these symptoms for one seizure, and they may have a different type of seizure that has different symptoms. But typically what we can see is oftentimes blank staring. So they're just kind of staring off into space. You feel like they're not really present. They're physically there, but mentally that you just don't feel like they're there. Sometimes a consistent chewing motion we will see, or fumbling around for things. Or you may see a student who's wandering around that still, again, is physically there, but you don't feel like they are mentally understanding what's going on. And then, of course, we see that the typical thing that we think of with seizures, that shaking, and then confused speech. So those are kind of the 6 main common symptoms, but I think it's important if you have a student with epilepsy that you're having a very in-depth discussion about what their symptoms are, and you have a very clear understanding, as well as the IEP dean does, of what their symptoms are. Some first aid steps. One couple of important things to remember. The first thing that we always do when we have a student that's having a seizure is we look at the clock. Okay, when we start seeing symptoms, we look at the clock and we start keeping a countdown. And the reason that we do that is once we reach that 5-minute mark and the student's still having the seizure, we call 911. That's our policy. Schools may have a different policy, but that's kind of what we use. The other thing is that when we're reporting to parents later about that seizure activity, it's really important for us to provide them with information on how long that seizure took. And so that was one of the other reasons that we keep track of time. We try to remove any hazards. Sometimes if we have a student that's having a seizure where they're really shaking, we make sure that their head is safe and cushioned. We don't put anything in their mouth. That used to be an old thing that they would say to do. We don't try to restrain them or hold on to them. We explain to the other students and we have them leave the room. So we have a safe space, and we just speak calmly to the child that's having the seizure and speak calmly to them until it ends. Typically, our kids that have seizures, when they're at our events, when they come out of those seizures, they're really tired. Sometimes they're kind of upset. Emotionally, they're overwhelmed. And so we have some things for each of those students that we know work for them. One really likes to go for walks. One likes to swing. One needs soft music and quiet and gentle light in the room to be able to calm after that seizure. So it really depends on the student what you do after the seizure occurs. But one of the most important things I want to encourage you to do is really have a good seizure plan in place for your students that have seizures and have a history of seizures. This is from the Epilepsy Foundation, and this is what we use within our program. We use this documentation. We sit down with the parents and we fill it out together. We talk about what types of seizures the child has, typically what happens when they have those seizures, how long do they last, how often do they have them. We also look at we just document what kind of seizure medicine that they're currently taking and any other kinds of seizure treatments they have. And then we look at what is our first aid for this student. What do we need to make sure that they need in place when they have a seizure? And then we also talk about any other additional help when they require additional help. For example, if the seizure is going on longer than normal, what do we do? What do the parents want us to do? If the seizures are clustered, so they're just happening one after another, what does the parent want us to do? And then it allows us to also talk to the parents about when we call 911. Okay? And what's nice is the Epilepsy Foundation kind of breaks down some general rules of when you would want to call 911. That doesn't mean that the parents may not want you to call sooner. You know, the typical rule is 5 minutes. The parents may say, hey, they haven't had one longer than 3 minutes. When they reach that 3-minute mark, we would much rather you call 911 and get help there. And then just has some contact information, documented, any kind of special instructions. That way the entire IEP team is on the same page in terms of how to manage those seizure plans. It also involves the nurse at the school. You want to make sure the paras working with the student are very aware of this plan and really understand what the steps are when the student has a seizure. Anyone that comes into regular contact with the student, you'll want them to be well versed in this seizure plan. When we look at some things that trigger seizures, of course, missed or late medicine. So if they're taking medicine to control their seizures, if mom and dad say, hey, our insurance isn't covering this next refill, we're running behind, or we missed a dose this morning, just wanted to give you a heads up, you kind of know that those seizures could be triggered that day. Also, emotional stress, sleep deprivation. When we have students kind of beginning their teenage years and going through some hormonal changes, we can see seizures increase. If you have students, I hate to say it, but even middle school into high school, using alcohol or drugs, those can induce seizures. Even things like mixed meals or maybe even a specific food or a specific drink can be a seizure trigger. That's why it's good to have that documentation with parents. So if you know a particular food or drink can trigger one, you can avoid that. And then the other good thing to document is if there's any specific stimuli that can trigger seizures. So for example, flashing lights is a common trigger. Sudden loud noises. I'll give you an example of one that we did. We developed a light box. It's kind of a sensory box. It was just a big cardboard box for a hot water tank, and I drilled holes all over the top of it and stuck Christmas lights through it. And then we filled it with pillows, and we have students who like to lay in there and just kind of look at the lights and relax. It's kind of a calming process for them. We had a student who had seizures, had never really had seizures triggered by lights, but she was kind of getting upset and needed to calm, and so we had her do the box activity just to kind of relax. Well, those lights really triggered a seizure for her and triggered a cluster of seizures, and so that was the first time the parents had seen that. We documented that. We added it as part of her seizure plan. They added it as part of the school seizure plan. But sometimes you just do things inadvertently that you don't realize are going to trigger that. So that's why it's really good to understand what those triggers are. So that's just a couple things on seizures. One more thing as I leave that, I just want to make sure that if you have a student that has a seizure, that I'm making that point clear, to have a meeting with the parents, and the nurse staff at your school, to really just lay out that seizure plan and make sure you have that all documented. So important. So when we're looking at determining the nature of specially designed instruction for our students with other health impairments or physical disabilities, one of the big tools that we use is called the school function assessment. And this is a great assessment for your occupational therapist or the physical therapist in the building to do with the student, because it looks at academic performance in the classroom, what that looks like, any kind of task supports that the student needs help with. So when we're talking about task supports, things like writing, completing written work, those kinds of things. Let me pull up my book here. And also helps us kind of identify any supplementary aids and services the student might need. And then activity performance, here we're just looking at functional activities that we need through cognitive and physical skills. So by doing this assessment, it really helps us identify gaps that the student has and identify those really clear supplementary aids and services. Also allows us to really clearly identify the accommodations and modifications that the student would need. When we look at some of those supplementary aids and services, here are just an example of a few that you may be writing into an IEP for a student with a physical disability or other health impairment. So the student may have special feedings, like Josie. She has tube feedings. We have a tube feeding schedule. We have physician orders that we have to provide each year that outline when those feedings are supposed to occur and how they occur, and how frequently. You may have a student that needs assistance with catheterization, or suctioning, or tracheostomy. We work with a student through our ministry that's the same age as Josie. She's the same age as my middle, Hank. She's in 2nd grade. She has a trach that requires suctioning. She can do that on her own now, but she also has a nurse that's with her every day at school that helps manage that trach, manages the suctioning, helps her with her tube feedings, those kinds of things. And then administering and dispensing medication. So, for example, Josie has some medications that she takes during the school day. That is all identified in her IEP through supplementary aids and services. The nurse is in her IEP as providing service time each day to manage those medications and the special feedings. And then also just planning for safety of the child in a school. So if you have a child with a physical disability, if they're in a wheelchair, if they use a walker, just making sure that the school setting is safe for them, that we have plans for them, for example, on fire drills. If you're on a multi-story building, that we have plans to help them safely exit the building quickly when we need to, those kinds of things. Also, just ensuring that care is given while at school and at school functions. So if they participate in extracurricular activities, that these supplementary aids and services continue. And also another big part of supplementary aids and services that I like to point out is this piece of conducting and promoting education and skill training for anyone that serves as a caregiver in the school setting. So this can look at like a variety of trainings that you could do within the school setting. So I'll use Josie as an example again. Each year, of course, Josie moves up in grade. She has a new teacher. That teacher typically is pretty familiar with her because her school building at the School for the Deaf is small. So they're familiar with her, but they don't know how to do her tube feedings. And then she also has a one-on-one para for medical reasons that can do tube feedings and help with some of her physical needs. So each year, the head nurse that runs the what they call the infirmary at the Kansas School for the Deaf, she does training for the grade level teacher that Josie is going to have, as well as the teacher below and above that grade level, because they often do field trips together. And then with any paras that are in their room on Josie's feeding tube, what happens if the feeding tube comes out, and then how to do the meals. And then they typically conduct training the first month of school. So if Josie has a new one-on-one para, they'll do a feeding a day with that para alongside her just to make sure that she feels comfortable in doing those specialized feedings. So it's also really important as you go through the IEP process on these students with physical disabilities and other health impairments that you really consider what kind of training you may need as a caregiver for them in the school, your paras may need, and write that in there as supplementary aids and services. Okay, give yourself some time within the IEP to provide that training. It's so important. And if you don't know how to provide that training, reach out to your school nurse, reach out maybe to a local physician's office. We have Children's Mercy here in Kansas City that can do some training like that. Lots of different ways to find those skills training, but especially if it's a particular impairment or physical disability that you're not very familiar with, that your team's not very familiar with, make sure that you make it a priority to get that training written into the IEP and documented. It's really important. The other thing that we want to really consider with these students, especially our students with physical disabilities, is assistive technology. One of the tools that we use for that, and you will learn about more as you move through your master's program here, is called the SETT framework. S-E-T-T. It stands for student strengths. E is for the learning environment, the tasks for learning, and then the tools being used. So you're going to read an article as part of this module activity about the SETT framework, about how we use it to really evaluate all kinds of things in terms of how instruction is given, how can we modify the classroom's physical arrangement, tools that we can use from low tech to high tech that would help students with physical impairments. An example, if you have a student with a physical impairment that has hand weakness, struggles to write, a really low tech tool is to use a big 3-inch binder. Have you seen those? 3-ring binder, and you put it on the table and the students use it as a angled drawing desk. Okay, don't have anything in it, just creates that angle for them. Sometimes helps with the writing process. That's a really low, no tech tool. All the way to high tech if they're using speech recognition to develop their written work. Okay, so I want you to take a close look at that article. It's got some great resources in it, and again, like I said, you're going to touch on this SETT framework much more within your program in other courses. But a couple of things that it'll talk about assistive technology from mobility. So when we look at, does the student need a wheelchair? Do they need a motorized wheelchair? Do they need a walker, a cane? What are we looking at for mobility? Do they need different seating options within the classroom? Those kinds of things. In the next module, we're going to take a close look at communication, and we're going to look at communication devices that we can use with students. Then we look at different types of assistive technology tools for typing, different writing devices, and then technology to just help with daily activities. My most intensive experience at working with assistive technology happened, probably 12 years ago when I was assistive technology coordinator at a school district here in the city, and we had a student who was a freshman, had just moved into the district, started practicing football at the beginning of the season before school even started, and he had an injury to his spine during football practice. Broke two spots in his back and became a quadriplegic. And so he had limited mobility in one hand, no movement in the legs or the other arm. And so he went to a rehab facility for the first 4 months of school, pretty intensive rehab facility, and then came back to our district and was in a pretty extensive wheelchair. And the rehab facility had trained him on using quite a bit of assistive technology in terms of doing some voice recordings, voice to text type tools. And you think this was 12 years ago. The technology's changed a lot now. Lots of different voice adapted tools that modified his environment. So even in his home, being able to turn the lights on, turn the TV on, was all voice activated. And the rehab facility came in and really did some great training with our staff to teach us really how to use the tools that he had been using over the course of those 4 months to be able to really adapt in his environment and to continue his learning. He went on to attend college and did well with those tools. But that's an example of a physical disability that can occur later on in childhood and really required some pretty extensive supports for that student when he came back to school. So we were fortunate to have a really good working relationship with his parents and the rehab facility, and so the team effort was there to really make it a successful transition for him back into the building. Some accommodations we can think about for students with physical disabilities, though, are things like changes to the room to make it easier to get around, time expectations, so giving them more time to work on an assignment, maybe expecting them to not be at school a full day if that's too taxing, modifying their schedule for the day, modifying how work's produced. So if we're wanting them to write a paper, looking at some different ways of producing that work that doesn't entail their physical disability impacting their final product. And then assistance for medical needs. So, sometimes these students need some of that one-on-one para support just to help with the medical needs. Oftentimes we look at para support for behaviors or for academic needs. Sometimes with these kiddos we need them just for those medical needs. So next steps, I want you to take a look at the Joy Zabala article called Ready, Set, Go, about the SET framework and how the SET framework is used to evaluate assistive technology needs. Joy Zabala is like the guru of assistive technology. She's been around a long time in the assistive technology world, has some really great resources on her website. And then I'd like you to complete the chapter review questions. Those review questions are going to be related to this instructional video, the chapter, and then Joy Zabala's resources. You'll also notice within the module I included some instructional resources like the seizure form, some documentation for that, some assistive technology ideas, just some other resources related to physical disabilities and other health impairments. And remember, don't hesitate to email me if you have any questions as you work on your chapter review questions.